Okay, so the goals of treatment. So what do we want to do? Well, obviously we want you to do as well as you can. So we want to maximize your periods of good mobility. We call that on time without dyskinesias. We want to minimize periods of poor mobility, and we call that off time by controlling symptoms such as shaking, stiffness, slowness, lack of movement and balance. And we want to minimize medication-induced dyskinesias, and we call that on with dyskinesia time and non-motor side effects. So we want to do as well as we can. So if we're going to just listen to this slide for one moment about the drugs that we can use.
Parkinson's disease is treated with medications. Most medications increase the level of dopamine in the brain or mimic the effect of dopamine. When medication increases the level of dopamine, this indirectly enables the basal ganglia
They took the microphone away.
levels, thus reducing symptoms in many patients. While medications can be used to improve motor function, it is possible that they may lose their ability to do so over time. When this occurs, the symptoms of Parkinson's disease may again become more pronounced.
So what that slide said, for those of you that can't hear, is that one of the main goals of drug therapy is to replace the dopamine that's not being manufactured in the brain anymore. As the disease progresses, though, despite being able to do that, this might not be enough therapy to treat your disease. So today's treatment, so the medications, and I'm not going to touch on this much more than this slide, involve dopamine agonists, monoamine oxidase B inhibitors, COMT inhibitors, anticholinergics, and amantadine. And there might be other medications that your doctor will be integrating into your therapy as well. So I do want to talk more about deep brain stimulation. So this is one of the fastest growing treatments for Parkinson's disease in the world today, and it involves a surgically implanted device that delivers an electrical stimulation to specific areas of the brain, somewhat like a pacemaker. It's been proven now to improve motor function in PD, and it's safe and it's adjustable. And there are about 40,000 patients worldwide that have been implanted with these devices. So how does DBS work? Well, it's unclear how DBS works, believe it or not, despite 40,000 people. But what it does do is acts like a brain pacemaker, and that pacing helps to mask abnormal patterns of firing in the diseased brain. So you're probably not going to be able to hear this slide either. I'll play it for those of you that can, and then I'll recap it. I'm sorry, that's unfortunately the best we seem to be able to do here.
Involves the placement of a medical device, much like a cardiac.
Well, it doesn't matter. This is not the wire.
Right by your knee.
No. I don't know what I'd be unplugging.
Stimulation of these areas enables the brain circuits that control movement to function better. This results in a reduction of some symptoms in many patients.
Okay, so again, stimulation in certain areas of the brain, and that's the subthalamic nucleus, but we'll discuss that, can result in improvement in symptoms in some parts of some patients. So who would benefit from deep brain stimulation? So if you've tried several drug combinations and you're still having difficulty controlling your movements, for example, you have too much off time, you have shaking, you have stiffness, you have slowness and lack of movements, and you have troubling dyskinesias, you may benefit. So you don't need to hear anything. So you can watch this slide, and this is a patient with bad Parkinson's disease. Typically, Parkinson's disease is on both sides, but many people are worse on one side than another. And this is the same patient with an electrode on and with the electrode off. And you can see, obviously, this is off and this is on, and significant improvements in her tremor in this instance. Improvements in her gait with stimulation and without stimulation. So deep brain stimulation has been shown to markedly improve functioning in Parkinson's disease patients. So when I see this slide, I guess the way I always think of it is everyone wants as big a piece of the pie as possible. So DBS, and this is from a large study published in the New England Journal of Medicine, which is one of the nation's premier journals, that patients with stimulation have a big piece of the pie, and patients without stimulation have a much smaller piece of the pie. So what we're talking about is threefold increase in the amount of time spent on without dyskinesias. So that's the bullseye that you're looking for, whether it's with medication, whether it's with surgery or what, is to land on this part of the pie. And whatever it takes, whether it's surgery or something else, that's where we want to get you. So again, what we say is that deep brain stimulation smooths out the motor function. So when we talk, again, we talk about these three categories. This is off. This is when you wake up in the morning and you haven't had your Cinemet yet. This is as the drug is starting to work and you're feeling good. And this is when it peaks and you're feeling dyskinetic. So sometimes maybe you feel like you're on a roller coaster, and you just want it to be a little more steady. So this is the way we like to picture DBS working, is it smooths out the valleys and the peaks. So does it last? Well, in big studies for five years out, and again, this is from the New England Journal of Medicine, we see that there's significant improvement. So these patients are, at 5 years out from surgery, are 75 to 80% better in rigidity and tremor, almost 70% better in dyskinesias, and 50% better in akinesia, in their slowness. And there are smaller studies that show that these benefits are durable even a decade out. This is just a very large study, so we trust those numbers better, and it's better stuff to tell you rather than saying a couple people down the block had this result. So we know it works.
Is it progressively better?
Is it progressively better? No, it is not progressively better. And in fact, these patients are still 5 years later are worse. But they're as much better as other Parkinson's disease patients, or as they are if you turn their battery off. So patients will still get sicker with the disease. That's the unfortunate fact of where we stand right now. But the effect is still as durable at that point in time. So this is a patient we operated on in Toronto. So again, she's very slow. She's happy, but she's very slow. She's asymmetric. She's worse on the right than the left. She stands up, and she has significant difficulty initiating her gait, beginning to walk, and in continuing her gait. And she has this slow, shuffling kind of appearance to her gait. So a lot of patients with Parkinson's disease especially have trouble turning when they're walking. Okay, and so this is the same patient. This is 6 months after deep brain stimulation. She has electrodes on both sides in the subthalamic nucleus. So she's happier. She's wearing a cowboy hat. She's Canadian. But anyway, so she's much more fluid. You can see that she's not rigid. She can stand from the chair without difficulty. So she turns and she walks down the hall. And she can turn around and walk back. So she's taken her Cinemet. So this is a patient on stimulation and on medication. So potential complications and risks. So I'd be lying if I said there were no risks. But as far as we're concerned, the risks for this are as low as we can get for any surgery on the head. And the risks that we can get, we do everything we can to minimize as much as possible. So there are surgery-related risks. So there is a risk of bleeding. Anytime we do anything, there's a risk of bleeding. And that risk is probably about 1 to 2%. There's a risk of transient confusion. So again, by putting electrodes in the brain, sometimes people will be confused. And we do things to minimize that as well. That's why, we have you see a neuropsychologist first. If they